health and mental well-being research in real-world settings. I am delighted to welcome you to this webinar. I'm Rocío García Carrión, Iker Basque Professor in Education at the University of Deusto in Bilbao, Spain, and I am involved in one of the projects that that is part of this webinar, which is Improva Project, and I will be the moderator of this webinar today. We are thrilled to be joined by a diverse and experienced panel of speakers from across research, policy, and practice, all working to improve mental health well-being through digital innovation. Today's discussion is an opportunity to reflect on how to implement the research being done by projects such as those of our speakers today in a way that actually makes it into people's lives in a meaningful and sustainable way. As many of you know, mental health challenges are on the rise across Europe and globally, and digital tools are increasingly seen as part of the solution. But moving from promising research to effective real-world implementation is rarely straightforward. We are here today to explore what helps, what hinders, and most importantly, what we have learned along the way. The Mental Health Dialogue Series is a space where researchers, practitioners, policymakers, and end users come together to discuss the latest trends, challenges, and advancements in mental health care. Particularly celebrating the European Week of Mental Health, we are happy that celebrate this webinar and that you all have joined us in this important discussion, which is organized by 7 EU Horizon Europe projects funded by the European Commission under the call for boosting mental health in times of change, and are supported by the European Health and Digital Executive Agency, HEDIA. Today's webinar involves a panel of representatives from each project who will be sharing their insights and experience on these very relevant topics. I would like just to mention briefly the project represented today are Advance, Smile, Meant Best, Reconnected, Improva, Bootstrap, and ASP Belong. This was the speakers you will be listening very soon. Before that, I would like just briefly to highlight just some housekeeping notes before we begin. Just for you to know, this webinar is being recorded and will be available on YouTube in our channel later in the day. And should you want to rewatch or share the webinar, this will be possible. We encourage you to join the discussion by contributing and answering the questions posed to the panel based on your own experience in the chat. So please be active. We're listening our speakers, sharing your questions, ideas, reflections. There will be a Q&A session toward the end of the panel. So please feel free to submit your questions using the Q&A box at the time during the discussion. I will be happy to moderate and invite our speakers to address your questions. If you would like further information of any of the projects, our chat moderator will share the links and the project website at the end of these sessions. So now let me briefly walk you through today's format. We are delighted to begin with a keynote speech from Sarah Brazis, our project advisor from the European Health and Digital Executive Agency. Following her speech, we will introduce a lightning round where each of our panelists will share a short insight from their own experience, responding to the question, what key lessons have you learned about engaging end users in the design or delivery of eHealth tools for mental well-being? So each of them will have around 3 minutes to answer this question. And after that, we will move into a moderated discussion where we will dive deeper into the key themes such as research policy gap, scaling challenges, co-creation, or digital inclusion. So we will then open the floor to your questions before wrapping up with some final reflections. Before we begin, I would just like to thank our partners from the Sabia cluster for helping bring this session together, and to all of you for taking the time out to be with us today. So with any further comments, let's get to start. I am thrilled to invite our project advisor, Sarah, to join us and to provide her introductory comments. Thank you so much, Sarah, for being here with us and setting the stage for our discussions today. The floor is yours.
Thank you, Rocío. And good morning, everyone. My name is Sara Brazis, and I'm the project advisor managing not one, but some of the projects represented here today. It is a real pleasure to be with you today. I'm very grateful for this invitation to open the fourth edition of the webinar series. And the title of today's session, From Research to Real-World Implementation, captures very well what is arguably one of the most demanding stretches of the entire innovation journey: the leap from tested and proven to adopted and sustained. At HADEA, the European Health and Digital Executive Agency, we support and follow dozens of mental health projects, eHealth projects under Horizon Europe and also Horizon 2020. And what we see again and again and again is that digital tools for mental health have become more visible, more accepted, and more expected than ever. But visibility does not always translate into easy implementation. And the transition from the research outputs to routine is rarely linear, as it was said. Even the most promising innovations face a very bumpy ride. So, from research phase, when meet real world scenarios, systems, and challenges. And this is not a reflection of failure. Rather, it's a sign that a space between science, human complexity, and policy intersect, and this is messy. Implementation, as you know, requires more than solid science. It needs trust, timing, tailoring, and also a bit of luck. And in this being said, I would like to briefly highlight three key themes we often observe in this space. First, user engagement. Engaging users, whether patients, professionals, policymakers. This is not just a box to tick. It is often the deciding factor in whether an eHealth tool is actually used outside a pilot setting. The difference between designing for users and designing with them is indeed more than just semantics. Second, the research practice gap. It is not unusual to see excellent evidence-based tools sitting unused because they're not interoperable, not reimbursable, or simply not understood by the people expected to use them. And bridging this gap requires a lot of work, aligning the research design with health system realities from day one. Third and final one, sustainability. Too often we see successful projects end, and that's it. No follow-up, no integration, no further scaling, no budget. And the energy just dissipates. That's why we encourage all projects from the beginning to think about the long-term pathway. Who will use the tool? Who will pay for it? Who will maintain it? And this brings me to something a bit more forward-looking today. As many of you know, the 2025 work program for Horizon Europe has been pre-published. And there are several new topics in there that touch directly upon implementation research, including on integrated care, digital health tools, and mental health system models. The adoption of the program is planned for around May, so still this month, hopefully, after which new calls for proposals will be open, and the deadline for submission, if I'm not mistaken, will be around late September. And this gives you some precious time to connect, partner up, position your idea, think about the future of your research. And in parallel, don't forget about the EU for Health program, which continues to support actions on mental health, workforce capacity, digital innovation, etc., etc. And its scope differs a little bit from Horizon Europe, but is still a very valuable instrument, particularly for scaling up and integrating the tools into regional and national health systems. And finally, I wanted to say that this kind of clustering cross-project exchange you're doing here today is exactly what we need more. It is in these focused topic-driven exchanges with a room for discussions, for sharing of best practices, for learning from each other that real synergies take place. So thank you for being here and for your work, for your resilience. And I know that working in digital mental health can sometimes feel like trying to change the wheels of a moving vehicle on top of a bridge in a very foggy night, but that's what makes it more meaningful. So I look forward to the discussions today, and I wish you all a productive and inspiring session. Thank you very much.
Thank you so much, Sarah, for these inspiring and thought-provoking reflections. Definitely, our commitment with that is at the heart of all the projects. And now we will be delighted to move on to the lighting talks from our speakers from the different projects. So, as I said, each project representative will answer this key question that we have put to all of them, which is what key lesson have you learned about engaging users in the design or delivery of e-health tools for mental well-being? While we will hear the answers, I encourage again all the participants to join the discussions through our Q&A tool. I will be introducing one by one, but just mention to give the floor to our first speaker. We will start with Bootstrap project with Dr. Lior Karmi. Please, I will like ask you for introducing briefly your role in the project and share your thoughts about the question we posed. Thank you so much, Lior, for accepting to be here with us today.
Thank you. Can you hear me and see me? Just want to make sure everyone is, yeah, now I can see myself. So thank you, first of all, for organizing this most important webinar. I think these questions are crucial for us as researchers and clinicians. My name is Lior, and I'm from the Bootstrap project, researching problematic usage of the internet across Europe, mainly in youth students, and using digital tools to assess and to intervene within the project. Specifically, I'm a PI from Reichman University in Israel, mainly dealing with the machine learning algorithms for the assessment, predictions, and intervention within the project. When I was approached by the organizers of the webinar, mainly on the questions of the lesson learned and the barriers that we have crossed across the way, both in research and in clinical practice within digital tools, it came to my mind that we need to separate those barriers. And thank you for Sarah for such a wonderful introduction for this subject, because I think she summarized a lot of the points that we all know. I would say that as for the clinical part, the first main barrier that we need to take into consideration that for most cases, we lack the clinical workflow integration, like many digital tools. And it doesn't matter whether it's passive sensing or digital phenotyping platforms or interventions. They're not designed within the realities of clinical practice in mind. I mean, we think research, we think how to integrate, how to take this tool into the population and try and want them to use it and then get the data and analyze it. What in most cases, we do not keep in mind the reality, the real world reality of clinical practice. And by doing so, we're lacking the integration into the standard cared electronic health records, for instance. So even if we have the most wonderful tool, it's hard for it to be integrated within the systems that those organization, clinical organization or health organization are working with. So my first point would be workflow integration. My second point would be, in some cases, insufficient evidence for clinical utility. I mean, we have great tools, we've done great research, but mostly for short-term flow, or for a specific pilot study with small participants, and so on and so forth. And then when we come to the clinical world, sometimes it's hard to convince the clinicians to use it, because the clinical utility and efficacy in some cases are not very strong. My third point would be that the data overload that sometimes it's hard for them to interpret it. And I've been part of several studies and companies that approached the clinician and said to him, we have plenty of data for you, really interesting data about sleep patterns, about behavior patterns, about whatever you want to have, and we'll have dashboard for you. And yet the clinician often says, or that I don't have the time for it, or that I don't really know how to interpret it. So as much that we are as researchers have this whole enigma solved in our head, we need to think about the translations process and the language we want to talk in order to make these tools much more useful. I want to just add a very quick 2 points, and I'm finishing. I'm not sure if my time is done. 2 points that I think are extremely important because they are not clinical related, but they are more system related. The first one is the legal and the privacy concerns, but not just about privacy, which we all know a lot about, but even like simple questions like who is the data ownership? Who is handling sensitive information? And we need to solve these problems systematically as a general acceptance before we move on to the healthcare organizations. Otherwise, we will end up in endless negotiating between these two main concepts. And the other one is Sarah, I think, mentioned as well, is the reimbursement and the business model for this. Who's handling the tool for long term? How the health organization are going to be reimbursed in practicing and using this tool. And I can tell you that, for instance, in Israel now, we're having like robust discussions about to integrate digital tools in the healthcare system. And one of the main issues is reimbursement for those organizations. So I think we need, in a European level, to think about those elements broadly and then have some kind of system that we are all accepting, and then we can move on forward with it.
Thank you very much, Leor. A lot of food for thought, and we can continue. So now we move on to the next project, is Meant Best, and I will invite Roberto Mediavilla to join us and introduce yourself and present your thoughts on that question. Thank you very much. Welcome, Roberto.
Thank you, Rocío. Can you hear me well? Okay, so very happy to be here, and thank you to the organizers. I'm representing Menbes, which is right now having its annual meeting. So yeah, I'll try to share my experience in how to engage end users. Not that much maybe in the Menbes project because it just started, so to say, and there's still some years to go. But in a previous EU-funded study, which Sara Brazis also knows very well, which is the Respond project. In that project, we in Spain, we used digital interventions to try and improve the mental health of health workers in initial pandemic settings here in the big cities of Madrid and Barcelona. Is where we performed our trial. And I think our key learnings, and I'm gonna try to be as short as possible, can be summarized in 5. Involving stakeholders, I think, influenced effectiveness. And I think this is a very important take-home message because of course, there's some literature supporting this, but it's very hard to prove that it actually happened. But when you are in the field and you know and you're involving end users in the process of designing an app and designing a trial, you see that whatever you're measuring and whatever you are delivering is meaningful for them. And I think that's one thing that clearly explained why we got such good results in our trial. not only it improved effectiveness, but I think it also has a great impact on implementation outcomes. And that also links with the key idea of this webinar and also what Sarah mentioned before, which is how we move from research to practice. And I think that's through implementation science. And we did some initial process evaluations in our trials, and we found that our interventions were well accepted, were feasible, and even in the long term, they appear to be sustainable in a way. Of course, we need money to prove that they are actually sustainable, that they can really be scaled up. And I'm very happy to hear that the European Commission is now interested in finding this kind of projects, in funding these kind of projects. And I will be very happy to move forward with testing this kind of interventions. The third point is that I think thanks to the stakeholder involvement and end user involvement, we now have a tool that can be scaled up more easily. It's in our case, it was health workers working in the Madrilenian and the Catalonian healthcare systems. We asked them how they believe these e-health interventions should look like and should be designed to be well accepted by their colleagues, to be well accepted by hospital managers, even by politicians, so that they can fund their widespread dissemination. And we believe that we ended up with this kind of tool, in part thanks to stakeholder involvement. We created a protocol for involving end users, an adaptation protocol that is actually very much strict but flexible in a way. The thing about having a research protocol for performing adaptations is that now that adaptations can be done in different settings. And actually in Respond, and I don't know if Mariana will mention this later on, we performed this adaptation in 4 vulnerable groups in the European Union using the same adaptation protocol. And that's very important because even stakeholder involvement can be done with a sounded research protocol. And last but not least, to me, and this is a personal experience, it made research more meaningful in a way. So it's not about only being in front of hundreds of thousands of rows of data, which belong to no one when you're analyzing them, but you're actually transcribing interviews that you've actually performed, and that makes our work, or at least my work, more meaningful. Thank you very much for listening.
Thank you very much, Roberto, for sharing all those thoughts, including experience. So now we move on to Reconnected Project. Our speaker, Claire van Genuten. Welcome to the floor and happy to listen to your thoughts.
Thank you very much. It's great to be here and happy to see that so many people are joining the webinar. My name is Claire van Genuchten and I'm an assistant professor in clinical psychology at the Vrije Universiteit in Amsterdam. And I'm here on behalf of the Reconnected project. And in this project, we focus on improving mental well-being of several vulnerable populations in Europe, taking a complex system approach. And one of the aims is developing and testing a web and app-based self-guided digital support system. And this system focuses on improving mental well-being, mental health literacy, improving community participation by the use of social prescribing, and improving psychological resilience with the use of micro-interventions supported by a machine learning algorithm. And as part of the project, we do involve the stakeholders in the development of the intervention. As part of the project, there is a generic intervention, though we adapt it to the needs and preferences of the population. This includes, for example, cultural adaptation. But we're still amidst a development process, so I think it's too soon to tell actually lessons learned from this project. But what I learned from a previous project in terms of engaging and engaging stakeholders in the development and testing the eHealth intervention. I think it's really important to be open, have an open view, be flexible, and don't be afraid to kill your darlings. Because in a previous project, we put a lot of effort in developing an intervention, but at that time did not engage stakeholders in the development process. And in the end, we did do a process evaluation. And during the process evaluation with the end users, it came across that some parts, which we really liked and which we put a lot of effort in it, they did not find it usable. So that's why my key lesson is learned. So don't be afraid to kill your darlings, even though it hurts a lot. But in the end, if people don't want to use it, then it's just, it may not be that usable. So that's my take on it.
Thank you so much, Claire. Very insightful and more questions to think about. So now we continue and move on to the advanced project. Looking forward to welcome Dr. Mariana Purgato and listening your thoughts on the question, Mariana.
Yes, thank you very much for hosting me. I represent the Advanced project, which is mainly focused on deepen our understanding on mental health promotion and prevention interventions across different types of vulnerable population groups in different countries in Europe. So, for example, in Italy, we are focused on asylum seekers, refugees, and economic migrants, while in other countries, like in Switzerland, our colleagues are focusing on older adults. In Vilnius, in Lithuania, our colleagues are focused on young people. And in the Netherlands, on employees exposed to advanced digital technologies. So some of the challenges and lessons learned so far are a mix of the experience that we had with Advance, which started in 2023, and also in the Respond project that Roberto already mentioned, and also in the Redefine project, again funded by the European Commission. So I would summarize our lessons with the eHealth interventions in three main aspects. The first one is related to building trust. So we work with vulnerable population groups. Oftentimes they are exposed to traumatic events and difficulties, and building trust is extremely important to engage them in the co-creation phase of the project, so in designing the work packages and the research activities, but also to engage them when we have to deliver the interventions. And in Advance, we are mainly delivering different types of WHO intervention strategies, similarly to what we did in Respond. However, here the eHealth component is very important, and we are also comparing different implementation strategies. The second aspect is related to the importance of being flexible, being culturally sensitive, and understanding the priorities of the target population groups. For example, in our experience so far with Advance, but also with other European funded projects, we saw that people may have different types of priorities that are different from mental health. For example, housing, work, family, and we need to be flexible to understand their priorities and to organize the research activities and the development and the engagement of people according to their personal daily life and their problems. The third one is related to the 2 points that I just touched, and is related to the relevance of our research. So if we want that our research is useful also, in the transitioning from research to implementation and then to scaling up of intervention, we need something practical. We need something that considers the pragmatic aspects of conducting randomized control trials, for example, but also adaptation studies. And we need to optimize our strategies in line with the types of population groups that we are engaging. And with Advance, we implemented some of these lessons that we learned in previous projects. For example, creating a work package specifically focused on the co-creation phase. So we engage already with the stakeholders and users of different types and different people participating in this delivery process in order to design different clinical and research scenarios in which people may receive the intervention appropriately. So considering their needs, their priority, and also what they feel is important. Because the last point, and then I conclude, is that sometimes what we feel is a priority based on the literature, based on our clinical work, is different from what end users feel as important and something to be prioritized.
Thank you so much, Mariana. Very important questions you raised as well from the experience of Advance. So now we will move on to the Improva project, and I want to welcome Felix Wolinski to join us from the Trimos Institute. So the floor is yours, Felix. Looking forward to listening to you.
Thank you so much, and also very happy to be here. Also, many thanks to Sarah for the very inspiring keynote and for also acknowledging that this work is very complex. I think we've also all come to realize that this is the case. I am a researcher in the Improva project, in which we are implementing a mental health platform in schools in 4 countries in Europe. And I want to look a bit back on my experience, but also look a bit forward and see what Improva actually did really well, in my opinion. And I also want to respond to 2 things that some previous speakers have I could really resonate with, which is Claire, who mentioned the Kill Your Darlings, and Lior about the integration. So I have 3 points in total. The first is focus of the intervention. I think when we start and when we think about research projects, we always want to answer the big questions. We want to reduce either suicide rates, we want to reduce depression rates. And from my own experience, also teaching in the Netherlands in a course that was really geared towards teaching future psychologists to use digital interventions in their practice. We organized hackathons with them to come up with interesting interventions that would improve the mental health of young people specifically. And depression is not always on the top of their mind. Within the system that they're in, they're much more concerned with the study pressure or with relationships, these kind of things. And while we tend to focus on depression and measure this as well as a primary outcome in our interventions, it's perhaps not always the most engaging topic to deal with in these interventions. So in that regard, also with the background of a not very successful randomized controlled trial, I can definitely feel something for the Kill Your Darlings. So very much in line with Claire there. Then the second part is the integration. Whenever we think about digital interventions, for a very long time, we always considered the anonymity and the possibility of using the intervention in your own time as sort of one of the core benefits of such an intervention. I think what we see now, also based on experience with Improva, but also other projects, is that rather than sending the intervention to someone that can just use it whenever they want, it is quite beneficial to think about integration. I'm coming more from a prevention background, so I'm not talking about integration into a hospital setting, etc. But in this case, for example, into the educational context. This is the infrastructure in which young people live and engage for most of the time during the day. So integration into that is definitely something to look at. And then a last point where I think we've really come a long way also with Improver is that from years ago where the randomized controlled trial was like a finished thing, and then once it was finished, once we had the results, we were thinking about, okay, what now? How can we implement it? We should probably ask for a new project funding for that. The field of implementation science is growing more and more. And hybrid implementation effective trials are becoming more and more prevalent. And at the same time, and I think we've done that quite well with Improver as well, new emerging research fields as well, like user engagement. Those are real experts, I've come to notice. It's not just researchers asking people, what do you want to have in this intervention, etc. There is a structured way and context around getting this information, and it's a dedicated field of research. So that's I'm very happy that this is this is coming more and more. I think we will talk later about in the panel discussion about further integration and funding, etc. Yeah, okay, sorry, I'm stopping. 3 points.
Thank you so much, Felix. Looking forward to continue the conversation afterwards in the discussion. So now let's go to the SMILE project. Welcome, Mel McHenry. So looking forward to listen to your thoughts on the question of lessons you have learned about engaging end users in the design or delivery of eHealth tools for mental well-being. Mel.
Thank you. So can you hear me? Yeah. So I'm Mel McKendrick. I'm an associate professor in psychology at Heriot-Watt University in Edinburgh, working on the SMILE project, which is still running until October 26. And it's developing a cognitive behavioural therapy designed inspired digital game to build resilience in adolescents and young people from age 10 to 24. The main thing that I want to focus on here is looking at the sustainable engagement and the steps required to achieve this. So the first lesson that we learned, as Sarah had mentioned, is the importance of involving end users early on and continuously. We ran a series of focus groups in the beginning to engage users and stakeholders, and this gave us some insight into the issues that young people worry about and their attitudes to digital mental wellbeing tools. However, we came to realise that we actually needed a deeper co-design approach to be able to achieve lasting engagement. We put more recently then together a public involvement group, and we did that as part of a voluntary research assistance scheme at our university so that we could involve students. They've been testing the game continuously so that they're really heavily involved with its evolution, and that means that we can gain a much deeper sense of understanding of what motivates end users. And for them, we involve them in all our research meetings and, show them the research process so that there's a real tangible benefit to them. But the project has shown us how difficult meaningful public engagement can be and the recruitment difficulties that can impact on the integration of feedback within the time frame. So it's really important to think outside the box and forge connections with people who can help. And we've recently been engaging with youth panels and science events, science festivals, for example, to ensure diversity of user engagement. And we're lucky that we're working across 7 countries and across schools and universities and community groups to help that diversity that's so important and actually sustaining the engagement over time. We know that users are also more likely to engage with eHealth tools when they feel that their data is secure and used ethically. So it's really important. We've tried to be very transparent about the data collection, the usage, the security, as Leor had mentioned, and how it's stored is really important, and how this is transmitted to the end users, so the young people, for example, in a way that they can actually understand. So having that transparency is really important. Also having the importance of having easy to navigate reliable digital tools, as Claire mentioned. So to achieve this, we've had dedicated substantial usability testing sessions, which were led by our partners Interest in Spain. And this has been able to help us to understand where there's technical issues or scripting elements that just don't make sense to the user that would halt engagement later on. So it's really important to not underestimate the importance of this stage or the time required to implement it. And lastly is the accessibility of equipment, I would say. So young people, for example, might not have their own phones if they're under a certain age. In other projects where we've been designing for older people, we found that they maybe didn't have access to laptops, for example. So understanding this from the very early design stage is really crucial. I think I'm probably out of time now, so I'll hand back.
Thank you so much, Mel. Yeah, another issues to continue thinking about and reflecting. And last but not least, we move to the project ASP Belong, and welcome Victor Coelho to share with us your thoughts and reflections to the question. Thank you, Victor. Can you open your mic? We can't hear you.
Sorry, can you hear me now,
Now,
right?
perfect. Yes, thank you.
Thank you. I was just getting my name of the project over here because there's a big one, but it actually explains all that we are doing here at ASP Long. It's the full name of the project is Augmented Social Play, Smartphone-enabled group psychotherapeutic interventions that boost adolescent mental health by supporting real-world connection and sense of belonging. And I always believe that titles this big would only happen in Monty Python films or the sort, but it is a mouthful, but it quite explains what we're trying to do. So we are a little bit different from most of our sister projects that have been described because we are directly working with students in classes. So we have three types of end users. We have an end user for the game, which is we are both developing a platform where augmented social play games and other interventions can be developed. And there is already one game, which we call ASP1, also called Lena, that will be played in 3 countries and trying to understand the effectiveness of this strategy. So our first end user is students. And so in the 3 countries where the implementation will take place, which is Portugal, Czechia, and the UK, we have been working with the kids through international exchange panels. So the kids from the UK have been to Czech in Portugal, the kids from Portugal to Czech in the UK, and the kids from Czech to the UK, from the UK to Czech in Portugal. In somewhat different groups, sometimes the same kids, sometimes other kids, and their role would be to co-construct the intervention that's named Lena. This was immensely useful because even though we have a group that's quite interdisciplinary, it doesn't necessarily include kids in the consortium, and their perspective as users was key to integrate a lot and to develop and to integrate several aspects of the narrative to know what was the focus for their priorities in terms of the emphasis on where the game should go or what the puzzles are more relevant, or even their input on the importance of customizing your character to play. And some of this was not necessarily apparent to our creative team, so they got a lot from it. And from the other people in the interdisciplinary field, it was also very relevant. I come from a background of school psychology, school and education psychology, and it was very rich to see how the kids would adopt different stands and different points of view from the developers of the intervention or even from other professionals. So And this is what we needed and what we did to get the kids to have a saying in the development of the main intervention. Our second end users is schools, because the kids do not opt to play or be part of this intervention. Schools do. And the intervention, because it's meant to promote, to reduce social anxiety and promote class cohesion and to promote well-being and reduce mental health issues, you play with your colleagues. So for an intervention to be promoted in a classroom, you need to get other people to approve it in these kinds of school boards. And so part of our work has been to both find schools where we can develop the effectiveness study. We had in Portugal, we already had a network that we worked on another project outside of ASP. Whereas, for instance, in Czechia, the partner for implementation was mostly in university, the same in Birmingham. And so it was a connection with the schools, and the establishment of some schools that were called flagship schools was crucial, because we needed somebody to be on board and willing to take this step in putting the intervention into the school in order to draw in other interest from other schools and other potential directors, or how do you call it, rectors in the schools. The third level of end users is the people who make the decision of disseminating this intervention. And those are government level structures or municipality, big regional structures. And those are different type of end users, because as of right now, we'll need to deal with them if this want this intervention to carry on being implemented after 2027. Otherwise, as mentioned before, it's all a little bit of useless, not useless, but it's wasted effort to create intervention. And if it shows any promise of working, and you don't make an effort to get it across the field to the people who might use it in the future, it's all been a little bit for naught. And so in every country that's part of the consortium, not only the implementing countries, efforts have been made in trying to identify barriers and key actors that may be useful in putting this out there in the future. So at our most relevant findings so far was the added value of including kids, not only in intervention and game design, but also in the beginning of the structuring of the intervention, and getting schools on board as soon as possible. But once again, we are focused in schools, and so we are directly working within the school element, and so we are probably a little bit different in that regard. Thank you.
Thank you very much, Victor. Thank you very much, all the panelists. I think you have raised critical questions, also inspired by Sarah's keynote and challenges, of course, and bringing us to what implies this real-world implementation from eHealth interventions to promote well-being, and especially the importance of the involvement of these end users, which is crucial, meaningful, and absolutely essential for these projects to happen and to achieve these big research questions that sometimes we put in this proposal, how to make that real. So thank you very much, very insightful. Thank you for you have shared reflections on the chat as well. And now we will move on to get deeper in some of particular aspects that has been already raised, but we would love to hear the thoughts of some of our panelists. So we will transition now to a moderated discussion. I will be posing some questions. We have three blocks of different sections of different topics, and we encourage as well an open dialogue to our participants. So let's begin with our first topic, that is the bridging research and practice. The question we would like to hear your thoughts is, what do you see as the biggest barrier to translating evidence-based research in eHealth for mental well-being into real-world practice? So what would you like to share with us regarding to these bridging research and practice questions? For example, you can start, for example, from Membest. Roberto, would you like to share any particular points on this?
Hi.
Can you see me? Because I cannot see
Yeah.
myself. Okay. So actually, I was thinking that I was about to mention adaptation, because I think one of the biggest, and I insisted on in this on on my previous talk, how important it is to have a tool that is adapted to the context where you want it to be implemented. But as I was listening to to all the speakers, suddenly I had this impression that this is actually more about accountability in a way, and I was thinking that we need to make policymakers believe that evidence-based interventions are better than interventions that are not evidence-based. And when I say evidence-based, I mean implementation, effectiveness, whatever class or type of evidence. Because sometimes I think policymakers they just want to deliver something and put a cross in the box that said, I delivered this, you know. And on the other hand, I also think that researchers, we need to remember that science is about moving forward. Sometimes, and I think Felix mentioned this, in the past we believed that the RCT effectiveness analysis results put out in a paper, it was the end of research. Well, that's not it. I mean, that's not useful. We've learned and data and research has shown us that that's not useful, because that doesn't translate into anything. So I think we also need to make researchers accountable for the type of research that they / we make. So yeah, I think adaptation, but also accountability.
Excellent. Thank you very much, Roberto. We would like to ask for our colleagues from at Reconnected and Bootstrap, Claire and Leo, to join in this moderated discussion together with Roberto. So the three of us, you can interact and intervene. Roberto raised the point of adaptation. So yeah, definitely Claire and Leo, if you want to share your thoughts on this question, please.
I'll start briefly and say that I completely agree with Roberto about the accountability, and I think the accountability will lead to integration. What I feel as the main barrier for us, both as researchers and clinicians, is to integrate sometimes amazing tools and tools that were tested and were found to be evidence-based, as Roberto said. But the institutions or the clinical practice is having difficulty to integrate them within their private practice, within their daily routine, within their own systems that they are working with. And I see this as a huge barrier, both for research initiatives, but also for private companies to make their tool work. I mean, if you're a private company and you just spread your tool in the App Store, that's fine. You don't need to be integrated in anything. So it's easier for you. You just need to convince me as a user that I'm gonna be good for you and you will gain something from my app. But we're not private customers now or private companies. We're trying to integrate the tool within a current existing system. This is extremely hard. And I think we have to understand, and it goes to the last question. We'll come back to this, and I'm finishing. I think we need to understand together. We are like 7, 9 projects within Europe. It's power. We need to understand, let's say we're all come out positive with the results and the research that we're doing. Okay, what would be the next step? We would want to go on each project with its own tool to the health organizations across Europe, to the stakeholders, and say, listen, we've done research for 5 years. We have positive results. The best brains, clinicians, and researchers in Europe, and we developed something, we need to integrate it. And we need funding for this, and we need acceptance of how we want to do it, and we need to understand how the system works in order to integrate it. So for me, that would be the challenge of integrating this. Thank you.
Thank you very much, Leo. Claire?
Yeah, I agree with Roberto and Leo, but at the same time, if you ask me, I don't think there's one central barrier or one biggest barrier, because it's really dependent on the kind of intervention that's being developed, who are the end users, who's in charge of the financing, what's the setting, for example. And I think all these factors determine which barriers are of importance. And this is also part of implementation science, which have really helpful frameworks such as the consolidated framework CFIRE, which also says there are multiple domains that all need to be in place and also depend. So there are multiple domains with several constructs, including accountability and the end users, that all need to be in place in order to ensure that an intervention is implemented or even maintained, or actually embedded in organizational structures. And I know, for example, now in another project I'm currently working on, we're looking to implement blended CBT for depression and anxiety within several large mental health care institutes here in the Netherlands. This has to do with the fact that we found great results in terms of effectiveness, and recently also the Ministry of Health made some agreements with large parties such as mental health care institutes that an agreement, it's called Integraal Zorgakkoord, which roughly translate to integral care agreement. And one of its goals is actually that 50% of suitable patients receive digital treatment to address the shortage in healthcare systems. And what we find now is that even though the intervention is the same across the institutes, blended care, patients are, well, the same, people with depression and anxiety. All the barriers are really different across the institutes and even within the locations of the institutes and even in the location within the teams. So now we're trying to map what are the barriers at this specific place and then try to make a plan that's really tailored to the location in order to ensure successful implementation.
Mhm.
Thank you very much. I would also invite to all the panelists to join the conversation. Actually, Leo, Claire, and also Roberto, they have already introduced a question of challenges or barriers, main or some of them, or the question regarding implementation, and that actually move us to the next question, but you can come back to any of the topics raised. So please just, I won't invite you to speak. Please do it by yourselves to move to the next question. As I said, related to this previous conversation, we would like to hear your thoughts and your discussion on what are the main challenges in implementation? As I said, this has been already mentioned, but what gaps do you encounter, technical or others, that slowed or block implementation? So if you want to come to this question with your thoughts, and also willing to listen all the panelists' thoughts and feedback on this. Maybe Peter from SP Belong.
Yeah, we come once again from a different point of view. Thank you for the direction, because our main focus is on thinning the herd, which means we do primary prevention, or we do a focused second level of prevention. And the idea here is to promote strengths in kids, promote their well-being, and get them to be in a good condition to promote their own mental health when they face with challenges. And so these types of interventions are supposed to help kids develop the skills, the competencies, and the know-how on how to deal with mental health issues that they'll bring on throughout their lifespan. So, for instance, we have directly 2 or 3 problems in terms of technical implementation, which is, as of right now, we are doing augmented social play. We're using augmented reality, and we're playing in schools with mobile phones. But we are a project that is running from 2023 to 2027. Which mobile phones? Because the mobile phones that we'll be using in the beginning of the the project that was the basis for development will no longer be in use for 2027. So one of the discussions that I'm school psychologist and educational, but one of the discussions we have been having, which is quite relevant, is what sort of platform, how open can it be, how flexible must it be in order to be relevant when the project ends? As this is a very simple kind of question. A second level is about your cost effectiveness. If you do evaluation of primary prevention interventions, your cost effectiveness will always be affected by the fact that the majority of expected benefits will not come directly after the intervention, not even at follow-up, but much later. So that would be the most complicated barrier to establishing the relevance of this intervention.
Indeed. Yeah. Thank you very much, Victor. Any thoughts on that, Mel? What's your view?
Yeah, I mean, I think our experiences, because we're still at the point that we're at in a project, are probably earlier than the later implementation stage, but it's so important to get things right at that early point. So I think one of the biggest challenges has been communication in terms of across different disciplines. And, and I've found this, in other projects as well, that differences even within clinical teams where you have different ways of doing things, you come from a different background, or differences between clinical and technical teams where, you have even one word can mean different things across different contexts. So it can take a long time just to get to grips with this. And it can result in misunderstandings, which can slow progress. So there needs to be time, I think, at the beginning of projects built in early on to be able to just build relationships and create dialogues that people can understand each other, which will then smooth that later implementation aspect. I think having goals that people have different ideas of what their goals are. So having a shared understanding of the goals, both in the terms of the project and then after, at the end of that project cycle going forward, is really important. So again, you need a shared framework, and somebody to manage that process is really important and mitigate when there are any issues. There can be, problems of dynamics, personality dynamics within teams that can halt progress. And again, going forward, that take up, it's really important to create a good dynamic so that after the project finishes, you want to then work together, continue to work together towards that implementation as well. And that can mean different priorities sometimes with commercial and academic partners. I understand that very well because I'm an academic who's also got a company outside of that. So that can create a lot of different types of priorities and timescales. And the lack of, this is something I know that Leo had mentioned, lack of interoperability, where digital systems, might be moving at different speeds, the integration, and how that happens, that needs to be planned really early on. And also just issues like, for example, data storage and where the location of that, considering GDPR and all of these kind of things. Again, I think it echoes what I was saying earlier about the very early planning and taking enough time before getting into the deep parts of the project just to iron out and make sure these parts are correct, because it will impact the later development.
Excellent. Yeah, great perspectives. And that's definitely these questions about the challenges and how deal with those are very close and very related to the issue of sustainability that has been also mentioned and present among our discussion. So that would move us to the third topic that we would like to tackle with you and discuss splitting it in two questions, would be the issue about specifically policy and sustainability. And with this third block, we would like you to provide your inputs or insight on how this EU level or national policy can better support long-term integration of digital mental health tools into public systems, or also reflecting about how proving cost effectiveness have a role in facilitation that integration of digital health tools into public systems. What would be your impressions or thoughts about that? Maybe comments from our colleagues from Improva best or advanced, that we would love to hear your thoughts and also invite the rest to interact on that.
Yeah, if I can comment on it, specifically regarding the policy. First of all, also since the European Commission or HDR is represented, things like the Digital Services Act really show that the European Commission or Europe is ready to give space to digital mental health and to tools like this. That's really good to see. I'm very proud to be a European when it comes to this. The question of how this is being translated to the educational context, what does it mean for people who want to implement one of the platforms in their schools? I think that's the gap. That's the gap, the translational gap. That's a bit on a higher level. Again, coming more from we basically have two, if we see it black and white, two systems, like really the care system, where there's regulations and policies required, and this is more my perspective, the prevention field. And I think one of the policy gaps, which is more and more tackled, is that there are no dedicated prevention budgets on a national level, at least in the Netherlands. And unfortunately, I think I can say that, unfortunately, we're taking a step back from having dedicated money available for prevention towards a shift again towards care, hospitals, etc. And I think for long-term sustainability of programs like Improver, once the project is over, these dedicated budgets and policies for having money available for prevention is really important. And then the last point, disclaimer, I'm German. I've been living in the Netherlands for 16 years. Two very different approaches. The Netherlands, when it comes to development of digital tools, digital eHealth tools, we're always really a front runner. Implementation and integration into the system, I don't know if Claire has a different opinion on that, always lagged a bit behind. So really developing fast and good, effective, but no implementation, also not into policy. Germany, on the other hand, took a long time and everything is very bureaucratic. This is what you probably have in mind when you think about Germany. They do now have this environment around digital health applications, DiGAs, which really allows finally to prescribe digital tools from the healthcare budget. Rather than making it a personal decision and relying on other tools, really having a funding mechanism, an integration, which still needs some time, into the system that allows the use of these tools. That's my perspective for now.
Thank you very much, Felix. Roberto, Mariana.
Mariana, go ahead.
Okay, now just very, very quickly, because I agree with all the points that Felix just mentioned. So thank you very much, because I think your points match also with the issues that we identified also during the implementation of the research project. I was also thinking about a specific funding in the long term for implementation, because, for example, once we develop these implementation strategies based on co-creation scenarios in advance, and after this project that lasts 5 years, we probably want these models and these implementation strategies to be scaled up, to be in some way integrated into the health system across different European countries. So having a long-term funding specific for implementation, and also specific for digital intervention strategies could be particularly relevant and important. And related to this, there's also another issue related to the regulatory requirements for psychological and psychosocial interventions. So we are testing new implementation strategies using innovative methodologies, and probably also the regulatory framework should consider these innovations that we are introducing. So I feel that the funding opportunities should go together with a renovation and a reasoning about these regulatory requirements.
I think I have a like complementary perspective on this because I don't know the EU very much. I've been involved in EU projects only since 3 years ago, and I was thinking more at the local level because we've struggled trying to implement our evidence-based best practice for health workers in my region. And I think, and I'm going back again to accountability from policymakers, and since these are called mental health dialogues, I think it could be very interesting to kind of, I'm going to use the word force or make researchers and policymakers and end users to sit together, dialogue, think, discuss, and then kind of have minutes and recordings of whatever is going on there. Because if I think of policymakers in my region and how we've been trying to force them into using our tool, which works, and how they repeatedly ignore our emails or do not reply, or why is that? I think because they don't see any link between votes and adoption of these kind of practices. So I don't know, my idea, my suggestion would be how, or to think about how can we make them hear these voices from researchers and from end users so that they can adopt what we believe that works, something like that.
Thank you very much. Please, Felix.
I just saw in the chat that the digas aren't working that well, so that's also the context. Wanted to respond to what Roberto said. Actually, these policy roundtables, we're also trying to, or we're doing these also in Improva. One thing that's really important to remember, I think, is that it's almost an intervention in itself. So when we're talking about these intervention developments, we have the digital eHealth tool, we have the digital tool, we have a randomized control trial, and then we have the problem that the funding stops after 4 years, for example, and then we don't know what to do. This policy engagement process suffers from a similar disease, let's say. So we also need to be transparent, and it's a matter of expectation management that within these projects, if we're integrating a policy framework in a Horizon Europe project, for example, then this can only be the first step, and we can make some first basic steps. But it comes back to the other point about integration and also having perhaps a different, more top-level approach. Only from within these projects, I don't think that's necessarily possible.
Thank you very much, Felix. I think in the conversation you have also connect with our last question, and I will invite Lior to join us to have a final thought, and also with the colleagues, with Stein, Felix, Roberto, and Mariana, the four of you. What do you think if Lior want to join? What funding or policy gaps still needs to be addressed for sustainable implementation? Some thoughts has been raised from Felix, Mariana, but in your views, and then we can open the conversation for this last reflection.
Thank you. Thank you so much. I want to take the opportunity that we're here all together to comment on Felix's points. And I want to tell you, Felix, that we are working closely with the DIGA that Germany has created. And we look at you in a way like our big sister, I would say, because this is exactly and I've read Sophia's comment as well about DIGA, and I understand it doesn't work smoothly, but it make it possible to start the basis how to integrate digital tool as any other medication or therapy. This is breaking news in a way. For the first time in our clinical health, digital tools may be prescribed as intervention and be reimbursement for that. This is a dream for us as researchers and clinicians that work with digital tools. So I understand there are a lot of problems, and we in Israel we didn't take precisely all the components of that's fine, but that's a basis for it's a basis for a working plan to see how we're doing it. And just to summarize it, I want to say that for me, this is the main thing I concern about, and I'm putting my emphasis on. And I think that if we could establish or to take it one step further from all those different initiatives within Europe to understand how to build this integration and implementation, like further funding opportunities just for implementations. For instance, if you were successful in your project and you have a digital tool that works, and you can, like the FDA, for instance, and you can convince us, the European committee, for instance, that it does work, then you could apply for implementation grant, for instance, style DIGA or style any other initiatives that we can talk about. But we need the framework. Otherwise, Felix says after 4 years of reimbursing, it's ended. We don't know what to do. That's okay. You have 4 years of doing something with it. That's amazing for me. We have nothing yet. So did you have 4 years? That's incredible. And the platform of like RCT is in 1 year and then so forth. We need these initiatives across Europe. So that would be my main take-home message.
Thank you very much, Lear. Felix, please.
Just because I think this was also a question in the chat. There was some confusion about what the DIGAs are. Sorry, I didn't explain that very well. It stands for the German translation of digital health applications. It's a very complicated process of research. Please, in the chat, correct me if I'm wrong. Of research, including cost effectiveness, evidence that you need to submit to the respective government body so it would be approved and basically available for prescription. That's the short definition. I really I fully agree with what Lear said, that this is really a first step. It's just having a framework and an idea to work on. And I think in the really shifting mental health sphere, where we also have the opportunity and the momentum of more attention towards mental health, perhaps we shouldn't aim for perfection and 100% integration right away. Having such a framework that we can criticize, take apart, take things from it that we want to integrate into policies in other countries, I think that's really great. That's what I would like to focus on.
Excellent. Thank you very much. If you don't have any further reflections on this, I think the discussion has been amazing. All the perspectives and contributions to the questions, complementary, very thought-provoking. And I would like to move us to the question and answer section for the last 10 minutes that we have. And it would be great to listen your answers from the panel. At the moment, there have some questions that has been already answered in the question tool and also in the chat. But yeah, we have a question we would like to open to our panelists, which we found very relevant from Elaine Henro. Thank you very much for this question. That is, how can e-mental health interventions balance the benefit of mobile phone intervention engagement with the potential risks or of phone addiction, and what strategies can be employed to mitigate these risks? So we are aware and conscious about these risks and of course balancing those benefits and risks. But yeah, we would love to listen your thoughts. Who would like to start? Benefits of mobile phone intervention engagement with potential risks of phone addiction and strategies to mitigate those.
I can start if you want, Rocío.
Yes, please.
Yes, because it's similar to one question that I saw before. And well, of course, there are probably dozens of strategies that can be used for this. But one we had experience with was because we use this self-help tool in the Respond project. It was a stress management program developed by the WHO that we delivered as a digital intervention. And we delivered it as guided self-help. So there was all the time someone, human person behind well, not all the time, but there were phone calls, there were messages that people could send in the chat. And I think that was something that made our tool more seen as like an aid or like something that is an additional support to what people need when they suffer from mental health problems, which many times is people supporting them and not just tools or digital tools supporting them. So my point is that I think that when you combine the delivery of the digital intervention with real people, it can help promote a better use of the technology.
Yes, thank you very much, Roberto. Please, Mel.
So I think that the intervention has to be designed right from the beginning so that it's for short-term basis and a lot of times so that it's used as a training tool in a sense so some of the work I'm involved in is for social anxiety, for example. So rather than aiming to keep people within the digital system, help them to develop tools themselves, psychological tools that they can then take out in the community and give them exercises to do that, so that part of what they're doing is a transitional process with the aim of helping them to put this into practice in real life where they're no longer using the digital tool over time.
Yeah, please. Thank you so much, Mariana.
Yes, just a follow-up comment to the one of Roberto, but also of Mel. I think they are related because in the experience that we had with Respond and also we are having with Advance, people have the opportunity of using these digital tools, especially the message system, in a proper way, because this tool is integrated into the intervention. So we can set up the rules and the way people can communicate throughout this app in a way that is structured, in which people know the rule very well from the beginning. So I think this method is particularly useful to avoid this kind of dependence, because they know they cannot keep messaging and expecting an immediate response from the other people, but they have specific moments in which they can send a message, and then they receive a response. So these types of rules should be clarified, for example, in the intervention manual for all the digital interventions. So if we have a specific rule, people can use this app in a proper way without being dependent from the system. And also I think that instead of using alternative ways of communicating, they could use something that is evidence-based, prepared by clinicians and scientists. So something in which everything is thought and is also shared with other people.
Yeah, definitely. I think, that relates very much with the reflections that other colleagues have said in the chat. And also, another reflection I would like to raise following up this important conversation that brings us an important point as well to geographical diversity in project implementation. From Gergana, she mentioned it's great to hear about all these projects across Europe. I hope some of the work in low resource settings, like parts of the Eastern Europe with limited mental health systems. So it's good that we can hear about those challenges too. This prompt maybe can be a final point for you to reflect if you have any views on inclusion and implementation in these underserved regions and how this could work to be adapted for low resource settings. What are your views or reflections in that? Any of those from more implementation considering this low resources context that are actually within our European countries?
I think it's a tricky question. That's why nobody is answering. This is what I think adaptation studies and adaptation processes are for, because I don't think, I mean, we cannot be so naive to think that eHealth tools will work for everyone everywhere all the time. So there might be some contexts and settings where eHealth simply does not do the job, and maybe there you need to invest more on having people delivering similar, interventions, but face to face, or using the mobile phone, or I don't know, maybe through other technologies. I don't know how specifically to suggest specific actions on how to deliver eHealth in this context, because I'm not an expert on that. But my experience in a very small pilot study that we did here is that many people still want to receive the same intervention, but in person, not in a digital format. And this is something we need to think about.
Yeah, thank you very much, Mel.
Yeah, I think on the other hand of that, there are cases where in countries that maybe don't have the same access, there is a problem of access, but maybe it's about being creative of having places where people can go to access the help. But also there are countries and cultures that are more stigmatized, for example, that don't want to have face-to-face because that has a higher cost for them, or they may be traumatized and are not able to get. So we were working with a project in Ukraine, for example, with children, and they weren't, at the stage where they felt comfortable talking to psychologists, for example. So it's trying to address some of that through digital help, in a sense. So I think there's as many opportunities as there are barriers to help people through digital mental health.
Thank you very much, Victor. Very brief, your last, and I will give you the last comment before closing. Your mic, please.
I'll go off a little bit off task. That's a daunting task, but the thing is, that answer will cover a different kind of situation, because if you're talking about mental health, the access to a mental health practitioner is different throughout Europe. One is training. We have loads of them here in Portugal and Spain. We don't do the most of it, but if you go for Portugal and Spain, we have the largest trained number of clinical psychologists per 1,000 inhabitants. And if you go to other countries, for instance, Germany, the level, or the UK, the number of trained clinical psychologists is low. So I don't think it's just a tech question. It's a health question, and mental health, and how you see what is your mental health provider. And here with the digital mental health tools, it's a cross-cutting field with several areas. But my best suggestion for lack of resources can be seen from a technological or access, and those have many different questions, the answers.
Okay, thank you very much. We would love to have more time, but there is 12:30, the time to close. It has been so inspiring. I think that they are addressing that challenge from research to real world implementation, our challenges and lessons learned. We would love to continue hearing your thoughts in the next webinar series. And we want to thank all our attendees. Special thanks to Sarah Brazis from the European Commission being today with us. And just we will continue with this challenge. Our young people and our children and youth in Europe deserve it, and promoting mental health and well-being is among our priorities. So thank you so much for all the thoughts. We will close this webinar, and I hope it has been as inspiring, as useful and thoughtful for all the participants as has been for all of us. Thank you very much for joining in this, and looking forward to continue the conversation.